the transportation piece, right? Is that a barrier? Is your phone not being charged a barrier? Paying bills, is that a barrier? So some of those seemingly small practical things could very much either make or break a patient's well-being.
Welcome to Protect, Suicide Prevention Training Podcast for healthcare professionals. I'm Manan, consultant psychiatrist, founder, and head of faculty at Progress Guide. Good day to our listeners. Today we have a guest with us, Yvette Bonilla, licensed and Masters of Social Work. She's the owner and CEO of Suicide Care Consulting Services. Mrs. Bonilla is a thought leader in suicide care space, a keynote speaker about post-crisis responses, an active contributor to her local zero suicide learning community, and an advisory board member of her local region's community crisis response team. Mrs. Bonilla has extensive experience in the healthcare and social service sectors. She has forged partnerships with hospitals and local mental health authorities, developing niche-based care for populations with complex care needs. She has also negotiated and managed contracts for providers and vendors, written and won tens of thousands in grant proposals, developed top-tier curricula for local government, youth projects, and more. Mrs. Bonilla is also a suicide attempt survivor. Her prior lived experience with suicide ideation and receipt of psychiatric inpatient care has equipped her with insider knowledge about ensuring a safe experience for patient care transfer and building optimal infrastructure to support safe, evidence-based transition practices. I actually came across Yvette on LinkedIn, and I was quite inspired by some of the posts that she made. And I reached out to Yvette, and Yvette has very kindly agreed to join us on this podcast today. And so welcome, Yvette. Thank you for joining us.
Yes, thank you for having me.
I understand you're joining us from Yale City, New Haven. Yes, and it's a beautiful place. I think it was 2009 I visited that place, and it's quite an amazing place. New Haven's quite beautiful with the colleges. You've been there for a long time. Are you born and bred over there, or?
Born and bred in Connecticut, and I have lived in New Haven specifically since late 07, early 08.
Okay, so almost a decade and a half.
About 15 years or so.
15 years, yeah. So, and I understand that outside that professional CV, you are a bit of a food connoisseur and you like to replicate recipes of food that you have tried and liked. Is that correct?
Yes. So let's say I eat something at a restaurant that I really like and I really like the recipe. I'm like, I want to make this at home so I don't have to keep paying for this. So
That's wonderful. That's wonderful. And you have a daughter and you're quite keen on helping her sell her craft.
Yes. She's my oldest and she's actually trying to sell enough of her craft to buy a 3D printer and do 3D craft.
Oh, so we have a little businesswoman over there.
Yes, sir.
And you have a toddler as well?
Yep, a 2.5-year-old and nice and rambunctious and everything.
Right. So you have your hands full and a lot of busy work as well. So you're one of those women who are kind of managing home, managing work, young family, all of that.
Yes, I have an 11-year-old, which is the craftswoman. Then I have a 9-year-old who is the academic, sort of the brains of them all. And then my 2.5-year-old and a 9-to-5 and my business. So busy.
Sounds like suicide prevention, at least from the quotes that I read and the post that you made on LinkedIn, you are quite passionate about that area of work. I was just wondering, would you share with our listeners where that passion comes from? What is the seed? What is the origin of that passion?
So the seeds is much like you mentioned, how I have lived experience with suicidal ideation. And it started at a young age, but I didn't get diagnosed until adolescence with a mental illness. They diagnosed me with depression and I had suicidal ideation as well. What especially inspired me to go into the field was pretty much in a very literal sense, this field saved my life. And coming into a field where there were people who were able to put a name to what you were going through, people who were able to walk you through how to navigate some of the challenges in your life, that was a very novel experience to me because for many years, no one really knew what it was. No one knew how to deal with it. And then when I actually came across trained professionals, they really helped me to map out how to get better and who to talk to when I needed help. And in many ways, I owe this field my life, and I've been in it ever since.
Right. And your own personal experience, and that is something you mentioned in your kind of professional CV, that how you draw on your own personal experience to support organizations and services in supporting people with suicidal distress better. Are there particular kind of experiences that stand out for you that you thought kind of personally when experiencing this, we can do better in this area, which has then gone on to influence the training that you yourself provide?
So what especially inspired me to start suicide care consulting was the concept of care transitions. Mm-hmm. So let's say someone goes inpatient, they undergo the curriculum, they get their psychoeducation, they get the individual therapy, any kind of family therapy with a support system, family or otherwise. And then it comes time to discharge. You have a whole checklist of things that you have to do, whether it's reconciling the meds and getting a treatment plan together, getting the discharge summary, getting all these things together. You go give it to the outpatient provider. And here in the States, the standard for transitioning a patient from inpatient to an outpatient appointment is 7 days. It used to be 14. And so there's sort of that gap, no matter whether it's 7 days or 14 days, where the patient has seemingly nothing. So It's kind of hard for them to know who they're supposed to contact in terms of following up. Like say if they have a question, or say maybe within those few days, they have like another crisis, or at least just sort of some issue where who do they talk to? Like if they haven't reached out to the outpatient person yet, or maybe they haven't met them, or if they did meet them before discharge, they might not really have that rapport with them yet, but they have the rapport with the inpatient folk. And then the issue happens where they have a relationship with the inpatient folk, but then they may say, oh, this isn't my patient anymore. And because of healthcare privacy laws, I don't know if I should contact this patient. So with all of that, that highly increases suicide risk. Yeah. And so that was just something that I was like, there's something that really needs to be done about this gap.
And the National Confidential Inquiry in the UK backs up all that you're saying, with the first week being the highest risk period, with days 2 and days 3 being when the risk actually peaks. So someone goes from the inpatient setting and they have gone back to all the problems which originally precipitated the suicidal crisis to begin with.
Yes.
And they haven't gone away. So they might have had treatment. They may be in a little bit more resilient space, but the problems haven't magically resolved. So they are going back into that space. So you're right. It's an absolutely critical time, and all the support on the inpatient side, if it's not kind of followed up, care transition doesn't happen seamlessly. It can lead to a lot of frustration. A lot of the scenarios, the dreaded scenarios, which the inpatient staff might have helped this person prepare for, might actually pan out if that support isn't there. So how long have you been running the suicide care consulting? Is it a fairly new enterprise of yours?
It is a new enterprise. Yes. Yeah. December 2021, I founded it.
Sort of, could you share with our listeners the kind of things that you would cover in the training that you all would provide?
So there are a few things, and where I get the basis of my framework from, it is heavily informed by the United States Zero Suicide Institute. What they focus on is trying to get suicide prevention done in all different areas of healthcare. It doesn't matter if it's mental health, psychiatric care, whether it's primary care or like a specialist healthcare. They're trying to get all these different kinds of people to screen people using the Columbia, for example, on whether or not someone is suicidal, and then they're able to go and refer to someone who has that specialized training, much like we do. And when it comes to care transition, I kind of noticed a bit of a gap with the services that they provide. So, for example, in Zero Suicide, when it comes to care transitions, they have a heavy focus on trying to get a seamless care transition from the emergency room. And rightfully so, because discharge planning starts from day one. And when you're in the emergency room, they don't want you in there for more than a day anyway. So they really want to make sure that you're de-escalated, that you have whatever kind of prescriptions you need. You need to reconcile past meds with new meds, and then go and refer them to like a psychiatrist, make sure that nothing conflicts, and then they do what they got to do. But when it comes to inpatient, that's where discharging from inpatient, there's not as much of a focus. And so what they really do is they try to get sort of like a task force together, right, where they'll have a supervisor, they'll have a clinician, hopefully someone who's like a peer staff. They'll get the financial representatives in order to fund the whole endeavor, and then try to work with everyone to have a comprehensive sort of infrastructure for implementing the framework. And so they sort of do that throughout the whole entire clinical process, where for me, I just focus on the care transition piece, where I say, okay, I want to take all of what they're doing in terms of sort of developing a task force, but I want to seamlessly focus on the care transition piece because it's such a fragile portion of care that leaves this big gap. So one of the things I do is, like, as part of the task force, have a financial representative to be trained on the certain billing codes and the documentation that needs to be written in a progress note for being able to fund the actual care transition services that they're rendering. So I provide training on that. I also, because in my
very pragmatic in that sense. So let's just kind of explore that a little bit, because I trained and worked in the UK, and about 4 years back came to Australia. So could you explain that a little bit more? And a lot of our listeners are in the UK and Australia. And they would not understand this bit, because in the National Health Service in the UK, there isn't that billing that you are describing. So in Australia, though, there are particular codes that would be put on, but it's still part of the same public service. Yes, there is the transitions between public and private as well. So treat me as a 5-year-old and kind of talk me through what happens in that space. So when someone's coming up to discharge, there would be particular codes that would allow for that person to receive the care that they need in those early days post-discharge. Is that correct, or?
Yeah, so that's the gist of it, actually. So depending on the insurance carrier, because in the US, as we all know, it's ridiculously complex. And so one of the big issues that happens when people are trying to put in a specific billing code for a specific service, let's say, for example, is something called transitional case management. And that can range from, like, say, someone going to a skilled nursing facility. Let's say they're discharging over to that level of care, or if they're trying to transition to outpatient, there's going to be within that model different kinds of codes depending on the level of care they're going to transfer to. And the way that the note is written is going to depend on what code you use, and also depending on where they're going to go. And so one of the pieces of training I offer is making sure, like, okay, if you're going to transition over to a skilled nursing facility, what kind of prep work did you use to get that person ready to transition to the skilled nursing facility? And, so then I would just do that across each of the different potential levels of care they're going to go to, so that they know the prep work is being done. And then that'll depend on how they submit the note and the rate that we can charge.
Okay. So yes, it is very pragmatic in that sense. So I can see that if this is not thought through properly, certain patients might actually miss out on the care that they might be eligible for. So writing up the documentation in a particular way allows you to then kind of put a particular code, which then allows them to get the care that they need in order to successfully transition and navigate this incredibly risky period.
Yes, and it also helps the hospitals out too, because they're also getting the funds that they need to continue to provide these services in the first place, because without the business, there's no way to service the customers.
Absolutely. Absolutely. So this in the Australian context sounds very much like what healthcare providers would do is there's a scheme called the NDIS where you get support packages. So from the public sector within health, our case managers would help write up those NDIS applications so that the right funding, the support package could be there. I kind of get that that's the same principle which you are describing there. Of course, this is really at the pointy acute end when someone's coming off hospital. What I'm talking about is perhaps more in the community setting for ongoing care, but I get that the principles are similar. So while kind of providing that kind of training, what have you found? What are the deficits you often find within in that kind of documentation piece? What are the things that often people miss out?
To be honest with you, they're just not familiar with the jargon that is often required in order for that to be processed. And sort of the really tricky thing is that it also depends on the carrier. So let's say public insurance like Medicare, Medicaid, they're going to want to see certain language.
Right.
But then say if you go to commercial insurances like say Anthem, for example, they're going to likely want to see something different. And so depending on the carrier, you're going to want to write certain things, and not all carriers will recognize the code the same way. So then, okay, which carrier will accept which code?
Yeah.
And then write it up which way.
Yeah. So it sounds like a fairly nuanced piece of training, but an incredibly important one, because without that, the person may not get the care that they need. So that's kind of one aspect. Are there other aspects to the kind of training that you'll provide in Suicide Care Consulting?
That's like the financial piece. Another piece that I also offer is just helping them to structure what a follow-up plan might look like. Mm-hmm. And so first and foremost, we try to get the client's consent in order to do the follow-up piece.
Right.
And once we're able to get that consent, then we kind of map out like, okay, one of the biggest things we might want to do, especially if they might leave at like a higher risk or so. And I know your model is a little iffy with the levels of risk. Just for now, that's what we have to work with.
Yeah, we kind of look, there is a spectrum of risk, and even though it's a continuum, at one end of the continuum there is low, and the other end there is high. So because of how dynamic risk is, we don't tend to categorize them into high, medium, and low. But a continuum will have a high end and a low end. So
right.
Yeah. So I don't think it's not the reason we are very opposed to categorizing risk as high, medium, and low is that often we use the categorization as a way of justifying the decision we have made. Like we are not admitting the person, we are sending them home. I would sleep better as a psychiatrist if in the documentation I would have written down low risk. The reality is, and anyone working in mental health knows that risk is so dynamic that it may be low now, but A, B, and C, if they change, it could very quickly go to high. So the low risk categorization almost gets in the way of us thinking through what are the things we need to do in terms of safety planning. So that's why we are opposed to the categorical way of thinking and stratifying risk. But we do know that we have a continuum and you have different points in the continuum.
Yeah, and I very much agree there. But for now, the system we work with is, let's say if someone is quote unquote low risk, but they do consent to the follow-up, then we'll try to get in touch with them within 24 hours right after they discharge.
Right.
And check in on how they're doing. And so what I'll do is like have sort of script supposedly just to say like, oh, how are you doing? Like you want to check on how they're doing, do a quick mental status check, and also see if they have any questions, like were they able to pick up their meds? Do you know where to go to pick up your meds? Because a lot of times the way that the mental health system works here is a lot of clients get used to things being done for them rather than with them.
Right.
And so they may not know, oh, they were supposed to go to the pharmacy themselves to pick it up or something like that. Or were they expected to make the call to make the appointment? And so like, do they have questions? The outpatient appointments are set up for them, but the client might not know that, for example, especially if they're just getting used to the system. Very important to say like, oh, do you have any questions? Do you know what time your appointment is? Do you know where to go? How to get there? And one of the biggest barriers, transportation. With COVID becoming a part of our day-to-day lives now, some places are starting to do more in-person appointments. And so what I always tell people is to reassess whether or not medical transportation is going to be necessary, and whether or not, say, if they're not eligible for medical transportation, because that is an insurance-based service, do they have a ride? Do they know how to get there? Do they know the public transportation system? So that is something I go through, as well as making sure that logistical barriers especially are eliminated on top of mental barriers.
So this reminds me of a central concept in Protect. We talk about relational safety, connecting with the person, meeting the person at their level, and really trying to get on their hill and looking at their life with the lens that they have. And these, again, simple but very effective ways of connecting with people. You know, how would you get from A to B, right? So we run a program in the Aspire module in the safety planning section called 127, which at the point of discharge, we systematically work through with the person what might happen in the next hour, the next 2 days, and the next 7 days, right? So, so it's a tool that we use. And the first hour questions are very simple. How are you going to get back home? Right?
Yes.
What's waiting for you there? Have you got the things you need? You know, there are 3 questions for the first hour, 3 questions for the 2 days, and 3 questions for the 7 days, 1 to 7. But they are just prompts to open up a conversation about, you know, how you going to get back home. It's not really about getting back home. It's get an understanding of this person's ability to get back home, their willingness to get back home. What are the transportation is available to them? Are they able to call an Uber? Or actually have they driven up to the hospital in their own car when in suicidal distress? And they're saying, I'm going to be driving back because my car's parked in the hospital. Thinking, oh my God, like you have been driving when you have been in that level of distress.
Right.
So a simple question can open up a whole host of things where you're really connecting with the person and getting to see their world from their point of view.
Yes.
So a lot of the things that you said really reminded me of that relational safety. You know, this is a person who genuinely does care about my well-being. And it's not just asking question after question, meeting their own needs of collecting data, because as mental health professionals, we need to collect data to make our judgment calls about risk and need and treatment, all of those things. And often they are our needs rather than the person's needs. And a lot of the stuff you said, just they are actual things that the person has to do in order to live their life. And that's quite beautiful that you all are kind of trying to get people, you know, connecting at that level.
So what I often find with a lot of practitioners is, especially inpatient, it's so fast paced. Honestly, no matter what level of hospital care, it's just so fast. And so a lot of times when they're setting things up, they often just give the patient a printout and like, oh, so here's your med list, go pick it up at this pharmacy, and here's your outpatient appointment. So it's just going through down the list. And so there's not much of a conversation that's really had with the patient in terms of, for example, the outpatient appointment and how they're going to get there, whether they're going to Uber, whether they're going to drive there, whether someone's going to give them a ride. And before COVID, transportation was the number one barrier to service. And now that's kind of up there with even telehealth, for example, because let's say, for example, I was actually talking with an outpatient provider probably a few months back, and they said the big issue with telehealth is, did they pay their phone bill?
Yes.
And so if they're not able to access it, even just to do a phone session, that can be an issue. If they didn't pay, like some companies in the States, they'll offer like a bundle package with phone, internet, cable. If they didn't pay that phone, internet, cable, they don't have internet to do video session. And so that can be problematic. And then couple that with a transportation issue. What I've seen some providers do is offer home visits. Like they've kind of had to weave that in as part of their care. And for a lot of places, that's a pretty new thing.
So I'm just thinking about this. So you may be, say, a psychiatrist or a clinical nurse consultant or someone who has looked after the patient, and you believe that you have set up the care in terms of there would be telehealth follow-up appointments. So in your head, you're thinking, right, follow-up is arranged. Follow-up is a large part of safety planning. And also in our head, thinking through what is the unaddressed risk. So you're thinking, okay, follow-up is arranged, but actually follow-up has been arranged only on paper unless these pragmatics have been looked at and sorted out.
Yes.
Like this reminds me of first hour questions. How are we going to get back home? And we often kind of say, they would say, oh, I'll just Uber, taxi. And they have been in the emergency department for say 24 hours, right? How long does the charge on a mobile phone last? The phone is completely dead. So along with their belongings, it's handed back. They go outside the hospital and the phone has got no charge. Something as simple as that can precipitate another crisis. And I think what you are talking about in a fast-paced, the challenge in a fast-paced environment, whether that be emergency department or the transit hub or after someone's been discharged, is mindful clinical practice, isn't it? Like thinking through from the patient's point of view, what would they run into? Have they actually got access to a webcam or on their phone? You know, have they paid those bills? Is there charge on the phone? And the mobile phone is such an important thing for people staying connected with their network.
Absolutely.
And from a safety planning perspective, I think that's absolutely critical. How do you overcome this challenge? You know, like people, healthcare professionals in that fast-paced environment, in their mind, they have already moved on to the next patient while they're running down the list of this. Because this patient's care is done, you know, like they're on their way out. They got another 5 people to look after and arrange care for. How do you get them to slow down? I guess that's one of the challenges that we face, isn't it?
It is very much a challenge. And I feel like a lot of them get the concept and theory about trying to practice mindfully. But for many of them, the fast-paced nature of the environment is just that difficult. And so another piece that I offer is also talking about mental health in the workplace. And so that is often a piece that I talk about is like, okay, yeah, you have like all these different task lists you have to do. And so it is very important though to just take a minute, and even if it's just those literal 60 seconds and just, you know, kind of slow down and do nothing. And if 60 is too much, try 45. If that's too much, try 30, because you'd be surprised. 30 seconds of silence is like just nothing. So just having that moment of just stillness can make it especially easier to just kind of literally clear your head and then say, okay, let me look at all of these different action items that need to be done. And so then what I try to get them to do and to work on is actually coming up with process, because I like to focus on, you know, process improvement initiatives, such as when it comes to discharging a patient, for example, having it on paper that we're going to talk about not just the things on the checklist, like the discharge checklist that a lot of them follow, but also some of those practical logistics, and have it on paper. Did they charge their phone before they left, for example? And did they arrange for transportation? You know, some of these things. So then at least it's on paper and it's something that'll be embedded in their policies and procedures. And then when you have it more streamlined, then it's a little easier to be more efficient and save several minutes throughout the day. And those minutes add up.
So it sounds like it's a two-pronged approach. One is to create processes, policies, procedures, which are almost systematized, so you follow them, but at the same time, using very simple mindfulness strategies to slow the practice down. So that you actually engage with the person. So the process guides you, but you engage with the person in a person-centered way to think through with the person what might be the challenges that they have to navigate, and think through those really nitty-gritty practical things the kind of concern that often parents will have for their teenage children, right? So, and that's where you show that I'm concerned about you and I care about you. Any kind of tick and flick risk screen or risk assessment that you do, that level of concern that another person really does care about me and is interested in making my life safer and better, goes a long way, goes much further than any tick box risk assessment exercise can ever do. So that's really nice. The fact that, you're just trying to take a minute, 5 breaths, slow down before you kind of dive into, we need to do this, and this. But 30 seconds, 45 seconds, that's all that you're asking for.
Right.
And that mindfulness might actually save someone's life or avoid a crisis.
Absolutely.
Yeah. You are a social worker by background. In your day job, you're working with other social workers, or is it a group of social workers, nurses, psychiatrists? Kind of tell us a little bit about the work outside suicide care consulting.
Okay. So I work at an addictions facility, which offers a very different model from the traditional, intensive outpatient programming. So in the intensive outpatient programming, typically what people might do is they might go to, say, like a hospital setting or even like a outside clinic, and then they'll do several hours a day of group work for several days a week. So let's say maybe 3 hours a day, 3 days a week. And they can run anytime in the daytime. They can go in the evening. So this addictions model is different than that. What they offer is addictions based in the home. So kind of like when you think of visiting nursing services, that's really where they got their model from, is offering services in the home, treating the patient in their home, and going through recovery-based curriculum that is largely led by peer-based recovery counselors.
Right.
And so those peer-based recovery counselors will go in the home throughout the curriculum. It's a 12-month curriculum. So it's a lot like what you think of like a step-down service, except it's a bit longer term because it is outpatient.
It sounds quite assertive in its approach, because in most addictions models, they kind of depend on the person showing the person needs to lead their recovery. If they aren't in the contemplation phase themselves, services don't tend to want to engage with them. But here, it sounds like you all go assertively engage them, help them move from pre-contemplation to contemplation to action. Addictions, that's another area where kind of suicide features quite heavily, not just in terms of access to means, but also often, people before they had fallen into an addiction, they would have had a life projection about where their life was headed. And every day that they are struggling with their addiction, trying to overcome that challenge, it veers off that projected path. And life ends off at a very different place to where they would have been. They might have been when in university, projected life might have involved a settled family, a good job, 2 holidays every year abroad, like all the normal comforts. And they might have ended up in their late 20s, early 30s, 1 bedroom in a bedsit, paid for by the council, living from benefits from one paycheck to another. So life ends up in a very different place. And often you do find that there is a chronic struggle with suicidality in a lot of people who are struggling. Had those kind of challenging scenarios at work to deal with as well?
I do. And that one is a lot trickier, I'll be perfectly honest, because what often happens is it can be especially difficult to know the origin of where that suicidal ideation is coming from. And because it's so complex, because not only might they have a co-occurring mental illness, they might also have co-occurring medical issues on top of that.
Absolutely.
And so we have people where like they might have developed, say, liver cancer or something. And, that especially can lead them to feeling suicidal. And they might get to a point where they're just tired of the chemo, or they're just tired of, feeling like a failure to their children because of their addiction. And then you have all these different social factors. And they may attempt. And a lot of times we really gotta just dig in there and see what it is more that we can do. And even in my practice, that's more challenging to address for all of us, admittedly.
Like, it's quite heartening to hear that you all are using peer workers in that role, because often in that support role, because it does capture hope for people to be able to, it's seeing is believing that here's a person who is supporting me, who might have had their own challenges, and they have successfully navigated through that challenge. And here they are helping me, trying to get better, trying to get my life back on track. That does, it holds up that mirror of hope. Yeah, there's nothing like seeing it in my own house. Here is another person who has gone through these challenges. That's quite heartening to hear, the power of lived experience and how that can help with hope and healing. So, which kind of provides us a segue into your own lived experience. Does that kind of link into the work that you are doing with transitions in care? Is that something that you yourself experience, sort of care breaking down at those transitions? Or is that something you witnessed while you were receiving care?
So both. I'll start with myself. So the first time that I went inpatient, what had happened was that I was about 16 at the time. I told my parents that I was contemplating suicide. So I hadn't attempted yet. And I told them what the plan was. And so because I screened like high risk, because I had the plan, the means, the intent, like I went and met all criteria pretty much. And I went inpatient, and I felt so kind of relieved to know that what I was going through was something that people actually are trained to deal with, that there was a name to it, that there are these things called coping skills, which I never even knew was a thing. Like, oh, to cope with stressors, like this is a thing? Okay. You don't just live with this stuff. And so that was a nice thing to know. And knowing that there were therapists who could back you up in case, say there was something that the parents didn't quite understand, or like maybe they might have thought, oh, suicide is wrong for this or that reason. Then a therapist could sort of walk them through about what's going on inside of my head as I told them, right? In ways where I might have had a hard time articulating that. And so once I discharged that first time around, I was supposed to do the intensive outpatient programming through the hospital. The issue was, though, it was supposed to start at around 3, but my parents were my ride. And so they didn't get out until 5. And so transportation was an issue in that sense, right? So big gap right there. And back in those days, kids didn't have cell phones. So
which era are you talking about, Yvette? Life without cell phones?
I know, right? No, especially as a 16-year-old. I was a 16-year-old and I have a cell phone. But so those are things I did not have available at the time, right? Not a cell phone, not transportation, none of that. But then when I went about maybe a week or so, and there was no check-ins with me anyway, like no follow-up. I don't even think my parents got a call just to see how things were going. And then the next thing I knew, one day I was feeling especially down, and I attempted, and they witnessed it. And
Your
I
parents?
sustained. Yes,
parents.
they witnessed it.
Right.
They witnessed it. And so 911 was called, and I had sustained injuries from that attempt. So I had to get medical attention. And then I went inpatient all over again. And then it was the same curriculum. I had the same providers. And so by that point, I kind of already had a good idea of the services that were going to be offered. And, so it wasn't like I was learning anything new, quote unquote. It was probably a good refresher, but because I had already been inpatient so soon before that, it was just more like, okay, I'm just refreshing my memory real quick, but I'm not really learning anything else. But probably the big change was because I didn't meet with the practitioner. And back in those days, that was when it was the 14-day window to meet with a therapist. Therapist, that regular outpatient therapist, happened to have been available the same day that I discharged. And so I think she met us at like 6, 7 o'clock or so at that same night. And so that way there was just no mistaking, you know,
falling through the cracks in the system.
Yeah.
Yeah. Like it's, thank you so much for so candidly talking about your own experience. Sometimes some horrible things have to happen for you to get the right care. It's just a sad reality of the healthcare service systems that we are working in. I'm curious about something. You mentioned that while you were on the inpatient ward, you kind of received therapeutic input. Was there explicit support regarding how you would navigate challenging scenarios in the community? The reason I'm asking this is that this is something that I find in our training quite a bit, that in inpatient care, they talk a lot about these coping strategies, internal coping strategies, you know, the stuff you can do by yourself, and then the external coping strategies, the stuff that you do with others. So there's a lot of talk about that. But I find that the focus is often on the ward itself, maintaining safety within the ward. Whereas recovery journey demands that we prepare people for the next step in their journey.
Right.
So I often see that there is a deficit there, that people kind of do all that. What do we do to stay safe on the ward? And what level of observations do we need on the ward? 10 minutes, 15 minutes, 30. But it's very focused on the ward rather than what would you need to do in the community. And the second thing is that although there's discussion about these coping strategies, they don't personalize it to the person. So, so say, for example, someone in suicidal distress would inevitably have a fair bit of psychological pain, right? A week stay or 2 week stay in a psychiatric hospital isn't going to change that. That psychological pain might have reduced a little bit, but the psychological pain would still be there. And the challenges that are going to come in the community, it may be that the risk tends to peak following arguments. The risk tend to peak when money runs out and, the next paycheck is still 4 days away. Or the risk tends to peak on the day money arrives, because that's the day people go out and buy a lot of alcohol and then get correct. So when in that protected hospital environment, we are often able to see those things, that's going to happen. That's what's going to happen in the community. But I often find that they do not get explicitly addressed. They may be implicitly there may be conversations. And I was just wondering, from your experience, did you see much of that scenario planning? What are the specific scenarios that would relate to you that might come up that you might have to navigate?
So what I would often find is that they would focus on small things. And so, because what the logic is that if you could focus on coping with something small, you could build your way up.
Yeah.
And so what I would see is say, they might give the example of, let's say there is a mess of pencils on the desk. And for some people, that might be very bothersome and it might trigger an argument. And so it would then be about how do you handle the argument? And so they might talk about, let's use I statements like, I'm upset that this mess is not cleaned up. And then they go work from there about how do they address that. And let's say, for example, it doesn't bother me, so I'm not going to pick that up right away. And I also have other chores to do. And so then it becomes more sort of convoluted, the conversation. And then the piece that's not talked about as much, I find, is, let's say, for example, someone comes with like a contradictory statement, and doesn't just say, I understand that you are upset about this pencil mess on the desk. I'm so sorry. I'll clean it up for you. What if someone doesn't respond that way? That's the piece that I often see doesn't get addressed as much as when they get backlash.
That's so interesting. So it's, on one hand, it's really nice that they're trying to start with something small from which it could be built up. And that simple conversation, as you're saying, can give rise to so many different pathways of conversations.
Yes.
But the most important bit from a, I guess, safety planning point is where there is a potential escalation of distress if you do not get that response. And that is what, in safety planning, we use this term called scenario planning, the what if scenarios. And you gave us a what if scenarios. You are assertive, you kind of make a statement, but you did not get the response that you were expecting to get. How do you deal with that? So that's a beautiful example, very pragmatic example of something which can give rise to a level of distress, or what we say if then scenarios. If this happens, then what might you do? And help the person to draw on their own strengths and draw on their own resources to navigate that scenario. So this kind of scenario planning really helps us individualize and personalize risky scenarios. You can do a bit of pattern mapping in terms of what are the familiar crises that the person presents with. So, for example, someone who may have lost his children, every time he has to go back home after having seen their children, and then they have a couple to drink, they might go through a period of suicidal ideation because they're missing their children, they're missing out on them growing up, and all those thoughts crowd into their head about what's the point. And, that is something that you can work with someone and map that out, that is a high risk period. How do you navigate that particular scenario? And solutions might be very simple, like, okay, I'll keep a photograph of my son in my wallet. After I see them, maybe I will not go home to an empty home. Maybe I will go and see a friend, so that the next couple of hours pass. So some very simple co-produced solutions with the person. And these solutions are different for every person, every situation.
Yes.
And do you find that in conversations with clients that they have specific scenarios of their own that they need to navigate through, almost like the things with transportation, which you were saying, they all kind of differ from person to person. Are there other scenarios that you pick up like that?
Yeah. And like you mentioned, they do differ from person to person. So a lot of it really has to do with what kind of support are they going to get? Because especially throughout my consulting, I really try to look for certain patterns that we can look for rather than how there's a lot of pressure to constantly tailor from person to person. And it feels like there's no sort of system to work with. So one of the things I really try to stress is supports throughout, as you say, pattern mapping. And so during the discharge period, as they're trying to plan out, there's a whole lot people can do on their own. But at the same time, people do need some sort of a support. And so that's something that I do try to help people look for. There are some people who will say that they don't have one. I'll hear that a lot, especially for folk who are going into a community-based setting, I don't really have anybody. And then when you sort of dig in a little deeper, there might even be a roommate that they have really developed a rapport with.
Yeah.
There might even be someone in their Alcoholic Anonymous group that they really connected with, right? So a lot of times when you're under any kind of distress, suicidal or not, you often are in this sort of a deficit mindset, right?
Yeah.
Where, I don't have anything. I don't know how to have fun or how to hang out, right? And so sometimes what I really try to just help people do is sort of map out their environment. Okay, there's no one probably say in your room, but is there someone, let's say if you live in an apartment complex, is there someone down the hall or even the security guard, right?
Yeah.
Maybe you've connected with the security guard, with the janitor.
Yeah.
You'd be surprised, security guards and janitors, they hear everything.
Yeah.
And they can often be a very good source of support.
Yeah.
Sometimes it's just anybody.
Yeah. So we kind of run in our safety planning program, the protocol SAFE, scenario planning, access to means, family, friends, follow-up, and emergency. Those are the SAFE, so the 4 letters. So the family, friends, and follow-up. We run a protocol called Circles of Trust. And it's like protect is just full of acronyms. So love is the acronym for that. So what you do is we list them. So the first L stands for list them. O is organize them on a matrix of helpfulness and availability. So on the x-axis, you have got helpfulness. On the y-axis, you've got availability. So the goal is to try and find perhaps 3 people who are helpful and available. The problem is that often there is no one in that the person can think of, or the person has burned all their bridges. And then that becomes a clinical focus in a way. How do you recreate that natural circle of support?
True.
And if you're not able to create that natural circle of support, then perhaps you begin with professional support. But the longer term goal to build up that natural circle of support. It was very nice you mentioned that. How can you perhaps bring into those circles of trust people who conventionally you might not think as someone who will be in that circle of trust? So you list them, you organize them. Then V in love is for verify what they know. So we draw 3 circles. So an inner circle, an outer circle, and outside the circles, right? So the inner circle is they know everything that they need to know. Those in the outer circle, they know something is amiss, but they don't know the full extent. And outside the outer circle, they don't know anything. So if there is someone who is actually quite helpful and is available, and they are outside, how do you bring them in, right, into those inner circles? How do you move them in? And we kind of say, so E in love is engage them. And we pin down the specifics of who is this person? Why have you picked this person? When are you going to share with them? What are you going to share with them? So in an inpatient setting where you have got someone there and you could spend half an hour just talking this natural circle of support and this professional circle of support through preparing them for that time where they might feel lonely on their own, no one to talk to, no one to share with. Like how you described your experience, you were with family, but still no professional to speak to, which, you had in an inpatient setting. So that piece of work that you're talking about is absolutely vital. A security guard or a janitor, someone you might not think about as a circle of trust, maybe, but that's all that you have got. That's a starting point. And then you can build on that. And if you go to AA, if you go to the church, if you go to, I don't know, the local gym or to the swimming pool, are there acquaintances you make, someone living down the hall? If someone had diabetes and they needed to be on insulin and they said, no, I don't want to take insulin, we won't just give up on them, right? We would try our level best to convince them to actually take the insulin because that is life-saving. Similarly, kind of having some kind of circle of support, however minimalist it might be, is life-saving. We know that. The evidence tells us that this saves life, and doing it proactively and prospectively. So it's great that kind of, those are the kind of things you all are picking up in that space where people, have been discharged and they are still finding their feet, in the community. And it's tough. It's tough for them that you all are making those little connections, helping them connect those dots. That's absolutely music to my ears. So Yvette, time just flies. So we've been chatting for a period of time and seems like almost an hour is up. Are there any particular words of wisdom that you might want to share with our listeners? Any top tips, any final comments that you might want to share with people?
I touched a little bit upon it already, but I would definitely say, look at the barriers to treatment, because a lot of the things that we write on paper, they're like beautifully mapped out and they seem to be very thorough. But when it comes to looking at the things that could get in the way of it working, that gets underestimated quite a bit. And so that is the one piece that I really like to talk about. Even if having a support system is a barrier, look at, anyone you might have been in contact with that you thought you might have connected with real quick, security guard, janitor, gardener, whoever. Yeah. Also look too at the transportation piece, right? Is that a barrier? Is your phone not being charged a barrier? Paying bills, is that a barrier? So some of those small, seemingly small practical things could very much either make or break a patient's well-being.
I think that's a beautiful note to end on, because we hammer on about these things in the 127 part of the SAFE training, that those simple, pragmatic, but very effective things that can make or break people. You know, I love this idea that do not assume, do not presume. Have that mindful minute that you talked about and think it through, looking at the world through the person's eyes to see, is this a potential challenge for them? Tease out those barriers proactively.
Yes.
Yvette, it's been wonderful talking to you. Thank you so much for taking the time out on a Saturday morning and connecting with us and sharing your knowledge and expertise. We really appreciate it. We wish you all the best in your endeavor, both with Suicide Care Consulting and the work you are doing in the addictions field, and wish you the very best. And again, thank you so much for taking the time out to join our podcast.
Listen, thank you so much for having me on your show.